This week on the BackTable Podcast.
It is when someone else is doing it. But then when you have to do it yourself, it's not so easy. So we get them all and we give them all the scans. It's okay, now you do it. And then we as the faculty walk around and check to see that they actually got it right and they actually understand what they're doing and actually do understand the anatomy. And then we give them the model and we say, okay, dissect the model. We don't demonstrate the dissection first because, again, if you've watched someone do it, then it's easy. So it's like a live case for them. It's a complex frontal anatomy which they have to dissect themselves. And when they finish dissecting the model, we then do the demonstration of what they should have done and the steps they should have done. And then I show them the video of the actual patient from which the model was made. So the surgery that I did on that actual patient. So those stepwise reinforcements of actually getting them, and we do it repetitively, so that you'll get in one course, you'll get to do 6 frontal recess dissections on 6 different complex anatomies. So that's the only way you can really train someone to understand, make sure that they do understand how to read a CT and understand the anatomy of that CT and how they can then proceed with the surgery.
Hello, everyone, and welcome to the BackTable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. Hi, friends and colleagues. We're thrilled to announce the launch of BackTable Plus for ENT. BackTable Plus features bite-sized learning modules created by ENTs for ENTs. The content is designed to be searchable, organized, and easy to digest, making it perfect for our busy schedules. Best of all, it's completely free. We encourage you to explore the platform and share your thoughts with us. Go to plus.backtable.com, plus.backtable.com, and click on ENT courses. Your feedback is invaluable as we strive to make this resource as beneficial as possible. Happy learning, and we can't wait to hear what you think. Now, back to the show.
My name is Ashley Agan. I will be one of your hosts today, and I'm joined by my bestie, Gopi Shah.
How are you, Ash? I'm great. I'm excited to be across the mic with you as always, and very excited for our guest and our topic today.
Me too.
All right, so we have Dr. PJ Wormald. He's a world-renowned rhinologist and skull-based surgeon who has been at the forefront in the evolution of sinus surgery and technology. He's a professor in the chair of Otolaryngology, head neck surgery at Adelaide and Flinders Universities in Australia. Dr. Wormald is here to talk to us about chronic frontal sinus disease, focusing on endoscopic frontal sinus surgery and keeping the frontal recess open. Welcome to the show, PJ. How are you?
Very good, thank you. It's a pleasure to be with you all the way from Adelaide. And our weather, I think, is probably better than yours now that you're going into winter.
Yeah, thank you. I'm glad we were able to find a time that worked well for all our distance across
several time zones,
lots of
countries.
So when we start the show, we like to give you a chance to tell folks about yourself and your practice. Not that you need an extensive introduction. I think most people know you and are very excited to hear from you today.
Well, thanks very much, Ashley. So I started off my career as an otologist, strangely enough, and I think there's a few of us who've done that around the world. I think of David Kennedy as one, and really took up sinus surgery in the late 1980s. Ran my first course in the late 1980s, and then started skull-based surgery in the early 2000s, and I've always had a real fascination for anatomy, particularly the anatomy of the frontal sinus. So it's been my sort of hobby horse to try and really improve the understanding of the anatomy, but also the surgical techniques in the frontal, because I really do think that the frontal sinus remains one of the sort of last challenges in sinus surgery, and the one that really sort of frightens or puts off a lot of surgeons from doing sinus surgery when they feel that the frontal is the one area where they can either get into trouble or the patients can have a poor outcome. So that's been my real goal in life, really, is to try and improve the outcomes and the training and the surgical techniques of surgeons in the frontal sinus.
That's awesome. So just to kind of set the clinical stage, how do patients with chronic frontal sinusitis usually present to you? And do you have a certain way you do your history and physical every time you see these patients?
The interesting thing is that, there's a lot of people who used to say you only operate on the frontal sinus if the patient's got frontal pain. And that's actual nonsense, because the frontal sinus is no different from the maxillary or the ethmoid or the sphenoid. All of the sinus contribute to the classic symptoms of chronic sinusitis, nasal obstruction, rhinorrhea, postnasal drip, and facial pain and discomfort. And it's not just the facial pain, which is the most important symptom. So when your patient presents to you, you take the history as you would for any sinus patient, whether it's frontal, whether it's maxillary, whether it's ethmoid, whether it's sphenoid. It's those major symptoms of nasal obstruction, postnasal drip, rhinorrhea, loss of sense of smell, and discomfort, facial pressure or pain. And to say that you only operate on the frontal sinus if you've got pain, I think is an out for surgeons, because they feel, because it's a difficult sinus to operate, well, we won't operate because the patient doesn't have any pain. And that's nonsense. If you want to get a good outcome from your surgery on the sinuses, you've got to address all of the sinuses that are diseased. So that's the key. Look at the CT scan, make sure that you have disease on your sinuses, and all of the sinuses that are diseased need to be addressed, not focusing on one particular symptom coming from one particular sinus. It's a conglomeration of all those symptoms and then the radiology and endoscopy that you would perform on those patients. And then once you have that.
How do you consider headache? A lot of times you end up as a referral for somebody that with a history of headaches, and maybe there's a little bit of nasal congestion. How do you put the headache symptom into the picture?
Yeah, I think headache in isolation is one that I don't actually have a good prognostic outcome for a patient, because a headache in isolation without any of the other symptoms associated with it is more often resulting from a myofascial pain syndrome or from a migraine or from other causes other than the sinuses themselves. Because for the sinuses to give you that poor outcome, the headache, the ether has to be a significant pressure change or differential, and that comes with baro trauma, with flying and things like that, and that's uncommon. Or there needs to be actual inflammation in the sinuses causing the wall of the sinus to be significantly inflamed. And so having that present without any of the other symptoms, you're not going to have a patient with chronic sinusitis with pus in it and then not having postnasal drip and not having the rhinorrhea and the associated symptoms. So headache in isolation is a poor outcome. And I try and discourage my patients from having surgery if they've got headache in isolation. That means that when you look at the CT scan, the CT scan is normal. I would not operate on a patient with facial pain or headache with a normal CT scan.
Yeah. I think that's a common thing that comes up. Definitely worth talking about. When you're looking at your CT scans, there's the obvious cases where every sinus is opacified, and you say, oh yes, there's chronic sinusitis, pan-sinusitis, all the sinuses are involved. I think the trickier cases can be, if the frontals have, some mucosal thickening, or, maybe there's some opacification of the anterior ethmoids or the frontal recess area. Like, how do you think about the decision to include frontal sinus surgery when it's not as obvious?
Yeah, I think, most of our patients, we will always give them that opportunity to heal themselves with medical therapy. So, most of them will put on washes, sprays, and if it's appropriate, if they have pus in the nose, we'll use antibiotics. If they don't have pus, we don't use antibiotics. It's a waste of time. So, if there's a purulent discharge, take a swab, do a culture-directed antibiotic course, and make sure that patient has the appropriate medical therapy. And generally speaking, we would give those patients a couple of months on that medical therapy to respond, and then do the CT scan. And then we should be in a place where your CT scan, your patient is optimally medicated. So if you're optimally medicated and you've still got disease on your CT and you still have symptoms, then those patients need surgery. And I like to say mini disease, mini surgery. Maximum disease, maximum surgery. So there's really only two options for me. The mini disease is the patients who've got, the sinus disease, which is sort of isolated to the maxillary, maybe a little bit of bulla, but nothing in the frontal recess, nothing in the posterior ethmoids or sphenoids. So they would get opening of the maxillary sinus and the bulla, and that's what we would call a mini fez. So a mini fez just for their mini disease. The patients who have got any opacification in the frontal recess, posterior ethmoids or frontal sinus, and they can have opacification in the frontal recess without having any disease within the frontal sinus. But if you're making that decision to go ahead and do the sinus surgery, for me it's all or nothing. Because the mucosal cells sit in such close apposition to each other, limited surgery or partial surgery in the ethmoids is, in my experience, a disaster. Because you're creating that inflammatory response, you're giving the blood clots to be able to connect between each of these mucosal surfaces. You then get in stenosis, and then you get in significant disease afterwards without having that benefit of having had the surgery. So when I do sinus surgery, it's all or nothing. So either all the cells are cleared from the frontal recess and the frontal ostium's opened, or that frontal recess is left alone completely. So it's an all or nothing procedure. So I basically have two surgeries. I either do a mini fez for mini disease, or I do a full house fez. In other words, all the sinuses are open. So it's one of the two, either complete surgery or minimal surgery, depending on the extent of disease on the CT.
Yeah, I like that. I think that simplifies it in a way. Like it's, makes it a little bit more black and white.
In terms of, with that approach, do you use that approach for kids as well? Kids with nasal polyps or allergic fungal sinusitis? How do you think about, your adolescents and pediatric population?
Yeah, I mean, that's a really great question, because we're much more conservative in children, because we find that in general, if you manage the allergies properly, you take the adenoids out and give them a good airway, a lot of them will improve significantly and don't need anything further. So that's our first step with the children, especially the younger ones, the ones below 10. You really don't want to be doing extensive sinus surgery on kids below 10. Obviously the children that have other issues like, cystic fibrosis or, ciliary dyskinesia of some sort, then that forms a slightly different category. But I'm talking about patients who have otherwise a normal immune system and functional cilia. We don't really want to be doing major surgery on those. And I would say that very, very uncommon for me to do any significant sinus surgery in child under 10. So for them, I would do, as I said, give them a good airway, take the adenoids out. And if they've got significant disease, pansinusitis, open up the maxillaries. Just give them a maxillary antrostomy, give them a good washout, and see how they go. And most of them will do really well. And if they don't, then, if they come back and you repeat the CT and all the other sinuses are still diseased, then it's the time to go in and do a full house fez on them. But it is a much more conservative approach and a much more sort of stepwise regulated approach in the pediatric population.
Yeah, sometimes I'm like, well, fortunately with CF, with some of the more, with the CF modulators, we're seeing that, not operating as much. They do better. But sometimes with patients that have CF or PCD, or in Texas, we had a ton of allergic fungal sinusitis, depending on the age, it's like, well, they're probably going to be back, right? Like this is their first surgery at age 10. How much do I want to do right now? The scan may only show a little bit of, more of the anterior disease, maybe anterior ethmoid and max. And yet we do have this underlying systemic issue, how much. And so that would always kind of be a decision-making point of sort of how to counsel and how much to do. Going back to the culture-directed antibiotics, let's say you're not able to get a culture. Do you have an empiric antibiotic choice? And how long are you trialing your patients usually for the patients that are chronic frontal sinusitis patients?
Generally speaking, if we look at what our cultures will be, in adults, staph is by far the most common bacteria. So if we don't get a culture and we still suspect or see purulent material in the nose, we would generally have an antibiotic which is going to cover staph well. So augmentin duofort, so amoxicillin clavulanic acid is one of the ones that we would go to. If the patient has had surgery before, or the sinuses are open, we will tend not to use oral antibiotics. In our experience, oral antibiotics are far, far inferior in terms of outcomes rather than topical antibiotics. So if you're able to deliver your antibiotic topically, then that is by far the treatment of choice. And so for staph, obviously we would go for mupirozine. We use a 0.05% concentration. And for the other alternative is levofloxacin, and we'd use topical levofloxacin as well. And generally speaking, that's delivered in a squeeze bottle wash twice daily in combination with budesonide, Pulmicort, as well as saline sachet. And so we put those all together and do that twice daily for a month. We found that if you use the treatment for less than a month, your outcome is not as good. So you really need to use that topical antibiotic treatment for a month. And we get really nice results with those too. If you have a Pseudomonas, we would often go to a tobramycin douche.
And so a significant amount of your patients are getting better just on that. Is that, if we're thinking about patients who've had sinus surgery?
Yeah, those are the
already?
patients with sinus surgery, yeah. So if a patient hasn't had sinus surgery, then it's an oral antibiotic. Topical antibiotics are a waste of time. You can't get them into the sinus cavities. So it's an oral antibiotic and if there's no ability to deliver that topically.
And if they've had sinus surgery but they haven't had frontal sinus surgery?
So again, it's going to be a combination of symptoms, endoscopic examination and CT. So, you got to look at all three if they're getting recurrent infections and on CT they've got diseased anterior ethmoids and frontal, they need surgery.
Are oral steroids part of your medical management for these patients?
Yes,
Do you do
so
like a
really interesting question because, when I started out 20 years ago, we used oral steroids as part of our maximal medical treatment on a routine basis. But more and more evidence has come in to show that, oral steroid use is cumulative through your lifetime. So as soon as you start, reaching that lifetime, what they call almost like a toxic dose, I think they're looking at something like 3 grams or something as your lifetime dose that you would be looking at. We've been less and less inclined to prescribe oral steroids. And certainly there's evidence now to show that, yes, oral steroids in a nasal polyp patient makes them much, much better, makes them feel better. The polyps actually resolve. But if you follow them up for 6 to 12 weeks afterwards, most of the polyps come back. So what have you achieved by giving them that prednisolone? So we've really, to a large extent, dropped the use of prednisolone from our maximal medical treatment. And we've also stopped using the prednisolone in the post, because we used to always give prednisolone post-operatively to patients who had nasal polyps. And now we've started to incorporate the steroid in the post-operative dressing that we put into the sinus after the surgery. So that's incorporated into that rather than to give them the oral prednisolone after surgery.
And with that change in your practice, have you, what have your observations been as far as like addressing the disease and inflammation? Like, is there much of a difference now that you're not giving patients prednisone?
I don't actually think there is, because I don't think it's like increased my rate of operating on patients, so in the pre-operative period. And I haven't noticed a difference in the healing in the post-operative period either. So, we've always said that inflammation is the enemy of healing. So that's why we used to give the prednisolone post-operatively, to try and reduce the inflammation in the post-operative period, to try and improve the healing. In other words, reduce the adhesion formation and preserve the ostia that you'd created. And really, with the new dressings that we have and the ability to use those in the post-operative period, we seem to not run into the same trouble that we used to when we were using prednisolone. So I haven't really noticed a change.
So PJ, let's say your patient that you saw who had, congestion, drainage, some headache. You scoped them in clinic. You saw a little purulent drainage, swelling. These symptoms have been going on for, 3 months. They're surgery naive. So you did the culture, you did the antibiotics for, you said, about 3 weeks. You've started them on rinses. You see them back in clinic now. Maybe it's been, 4 to 6 weeks since your last visit. When do you start thinking about surgery? Let's say the symptoms haven't really gotten any better. How do you counsel the patient about next steps? And, what are the kind of goals when you talk to the patient about the next stages in management?
Yeah, I think that's really interesting, because I generally will see the patient 2 months after I've put them on the maximal medical treatment rather than 4 to 6 weeks, because I would really want a CT scan when I see them again, when they come back, if they are still symptomatic, because the CT scans take quite a long time to resolve on a scan. So if you see them too soon, you might be in the resolution phases where you're seeing disease on the scan, which is actually still part of that original infection that they had. So I think 2 months is a good period to see them post-op, because if they are not responding, they'll still be symptomatic. So that's important. So the patient needs to be, we don't operate on an asymptomatic patient. The easiest thing to do is to make an asymptomatic patient, which doesn't have symptoms, symptomatic. So, if they don't have symptoms, don't operate, because it's not going to, even if their CT scans are abnormal, we'll say to them, listen, if you're asymptomatic, come back when you're symptomatic. Then we'll operate on you, because then we can make you better. Can't make you better if you're well as it is. So that's important. So they must have symptoms, and they must have some sort of evidence, either endoscopically or radiologically, that there's an issue. So sometimes you'll look in and they're still symptomatic, and you look at the CT scan and you say, well, not much there. But if you're looking with your endoscope, you might see an accessory osteum and circular flow in the maxillary, which doesn't give you a radiological change. But you must be able to see some disease or some sort of pathology to be able to operate on the patient. And then at the end of the day, I say to the patient, this is your call, okay? So this is a quality of life disease. This is not going to kill you. So you've got to decide, how badly is the symptoms that you're experiencing affecting your quality of life. And if that is affecting your quality of life to that significant extent, then you must be prepared to undergo surgery for us to be able to fix it. And so if your symptoms are not affecting your quality of life sufficiently for you to want to undergo surgery, well, then come back when it is, and then we'll operate on you then. But, we don't try and persuade patients to have surgery. I think that's a very unhealthy way to approach your patients. If you make the patient make the decision, then you're always going to be in the patient's favor, because you haven't tried to persuade the patient to have surgery, and the patient's been symptomatic, and you've given them a good explanation about what you can achieve, and the patient's expectations and what you can deliver are more aligned.
And in the meantime, if you have a patient who is not ready for surgery, you just continue rinses and, topical steroids and things like that to just kind of be doing something, or it's just like we'll treat the sinus infections as they come with antibiotics and go from there?
Yeah, so I generally say to the patient, if they come and they've got disease on the CT and they're still symptomatic, but they still feel they don't want the surgery, I send them back to their primary healthcare physician for continued care, and say to them, I'm here. When you're ready to have your surgery and your symptoms have got to a point where you feel they justify you undergoing surgery, come back and we'll see you then. I don't follow them up for their regular infections or for their, they've got to, we surgeons, we're going to fix the problem for them. We're not primary care physicians going to look after their sinus infections while they're having them. So, when they're ready for the surgery, come back and we'll sort it out.
When, let's say, the patient is ready, they've gone through the options, they've thought about their quality of life, and they do want to go ahead and proceed. How do you start to prepare for cases? How do you look at scans? If you, with 2 universities that you're at, you probably have medical students and residents and fellows. How do you teach them?
Yeah, so, that's really the area where I think that we have significantly improved over the last 10 years. We are much better able to teach the surgeons to understand the anatomy on the CT scan and to plan their surgery. So I really focus on CT scans. And I think one of the problems we have with training surgeons is that when you go to a sinus course, which is cadaver-based, you might have 20 cadavers in that dissection hall, and you might have 2 or 3 of those cadavers that have complex frontal sinus anatomy. And the rest of them will have a single agar cell or almost nothing, or, you put an endoscope, you look straight up into the frontal sinus. And so, one of those 3 with complex anatomy, the demonstrators are going to take. So you're going to end up with 2 for the delegates, 18 delegates who, how do you teach someone to understand the anatomy and to actually do the dissections on someone who doesn't have complex anatomy? So, the whole premise of actually teaching and understanding complexity, and they can be very complex, these CT scans, and actually working out how to dissect each cell and plan your surgery really needs to move away from the cadaver lab. And, that's where we've been innovative in terms of trying to develop models which are made from actual patients. And so what we tend to do is we run courses now where the focus of the course is for the delegates to do the planning. So what we do is we give them the software, which I'll demonstrate for you in a moment. We give them the software and we say, okay, you work out what the anatomy is, form a 3-dimensional understanding of the cells in that frontal recess, identify the frontal drainage pathway, and plan your surgery so that you open each cell consecutively. You know exactly where you are all the time, and you can then do a complete dissection safely and completely for that patient and complete that surgery. So that sequence of actual doing that is we get the delegates to bring their own computers and we give them the CT scans and we get them to do it, because easy to watch me doing it on the lecture stand. I'm up there and I'd go, yeah, this is it, that's it. And then everybody sitting in the audience says, oh, that's pretty simple, that's easy. It is when someone else is doing it. But then when you have to do it yourself, it's not so easy. So we get them all and we give them all the scans. It's okay, now you do it. And then we as the faculty walk around and check to see that they actually got it right and they actually understand what they're doing and they actually do understand the anatomy. And then we give them the model and we say, okay, dissect the model. We don't demonstrate the dissection first because, again, if you've watched someone do it, then it's easy. So it's like a live case for them. It's a complex frontal anatomy which they have to dissect themselves. And when they finish dissecting the model, we then do the demonstration of what they should have done and the steps they should have done. And then I show them the video of the actual patient from which the model was made. So the surgery that I did on that actual patient. So those stepwise reinforcements of actually getting them, and we do it repetitively so that, you'll get in one course, you'll get to do 6 frontal recess dissections on 6 different complex anatomies. So that's the only way you can really train someone to understand, make sure that they do understand how to read a CT and understand the anatomy of that CT and how they can then proceed with the surgery. And I'd just like to share with you, if I can, then my screen here and then show you just a little quick frontal recess and how we go about it. So if we look here at this particular patient, so this is a patient who's on the left-hand side, has got a significant complex anatomy. There's an agonase cell, there's a supra-agar frontal, there's a frontal septal cell, a very large frontal septal cell as well, and then the frontal drainage pathway is going posterior to these cells, as we can see on the axial scan as you slide down. So using the software, we can then plan this. So we can then take the building blocks and create this 3-dimensional model of these cells. So we can then have that understanding in our heads exactly what that anatomy looks like. We can then put in the drainage pathway so that when we go to do the dissection, we can then understand that process. So here we are in the model. We're going to do the axillary flap first. We're going to raise up the mucosa to expose the anterior face of that Aganase cell. We're going to remove that Aganase cell with a Hayjack-Koffler punch. And that's going to expose that Aganase cell so that we can visualize into that Aganase cell. And this allows us to use less angled scope. So here we are taking away the posterior wall of the Aganase cell. And when we do that, we're going to visualize the supra-agar frontal cell, which we can see laterally. And immediately, we can see the opening here into the frontal septal cell. So we can then see these are the 2 major cells obstructing the frontal sinus. And we said when we looked at that scan, the drainage pathway was posterior. So we can go posterior and we can fracture those cells anteriorly to then expose that frontal ostium. And then using angled instruments, the instruments that you would actually use, the surgical techniques, because it's about positioning of your instruments, about visualization, that you can use this cobra punch to actually remove this. And the technique of doing that is not as simple as it looks, because you are working around the corner with angled instruments and removing those cells. And again, here we are just taking the bulla down to complete that frontal recess dissection and then expose that anterior ethmoidal artery, which we'll see comes just as we take the top of that bulla down. We start to visualize that anterior ethmoidal artery and then complete that dissection of that frontal ostium and then be able to see that. Now that software is available, and hopefully you guys can put the links up for everybody who's listening to the podcast, and you can download that software for free from Stryker. That doesn't cost you anything, and you can upload any of your patients' CTs or MRIs to that software and actually do this planning. Because what we found is that surgeons who do this on a regular basis, we have a resident for 6 months. And after 6 months, all of the residents, because we do this before every single case, and after 6 months, all of the residents are able to do a complete frontal recess dissection on a complex anatomy. And it's just repetitively doing it so that they understand the process and understand the sequence of how we do and how we go about it.
Yeah, it makes sense. You just got to get those reps in, get that muscle memory, understand, the spatial relationship of all the cells.
And it is applying like the CT to your endoscopy and then going back to your CT and kind of seeing, and then, because what you think you might know from the scan, but then actually seeing it on endoscopy, you're like, oh, is that the frontal or is that, or, because sometimes you're like, or is that skull base, or do I need to, so it can get tricky for sure, where it's like, well,
I say to the residents, so, you've done this 3D planning. Okay, you've got your models. You've got an agonizing cell. You've got a superagar cell. You've got a frontal septal cell. You've got a posterior drainage pathway. I said, okay, we open up the agonizing cell. When you look up with your scope, tell me what you're going to see, and tell me where the drainage pathway is and what you're going to see. So you look up. So it's okay. Look up. There's the agonizing cell. Okay, where's your drainage pathway? Where are you going to put your instrument? This is before we operate on the patient. So they say, okay, there's the agonizing cell. I'm going to put my instrument posterior because that's the drainage pathway. I'm going to fracture anteriorly. We are very keen on the frontal process of the maxilla. So that hard bone of the frontal process, we call that the hand on the wall. So one of the commonest reasons that you get a complication in frontal recess dissection is that you are probing for the frontal ostium to posterior. So when you're pushing your instrument to posterior, you go through the skull base or into the orbit. And those are the two things we want to avoid. And that's what makes people scared of doing frontal sinus surgery. So having that frontal process, I likened it to being in a maze. So if you're in a maze and you're lost, you put your hand on the wall and you don't pick your hand off the wall, you'll get out the maze. And I tested it and it works every time. So I said, if you're in the frontal recess and you've worked out your 3-dimensional cells, what you do is keep your hand on the wall. So you keep that frontal process in view during the entire dissection, and you understand how your cells relate to that frontal process. So that when I say to the resident, okay, agonize your cell, frontal process, you got your hand on the wall. You know exactly where the agonize, take the roof, the agonize your cell away. Okay, you know I've got a superagar frontal. Now the superagar frontal, what is the relationship of your superagar frontal to your hand on the wall? And your drainage pathway. Is it pushed anteriorly, pushed medially? How is that related to your hand on the wall? And then where are you going to look for that drainage pathway? In other words, you have to have identified it. And I say, if you take a bottle and you take an upside down bottle, the neck of the bottle is where the cells push in and narrow that drainage pathway. So use the axial scan from the top down to follow the drainage pathway through those cells and understand how it goes between those cells, and then put your instrument up the drainage pathway, fracture onto the hand on the wall, which is safe, take those cells away and expose that frontal ostium. So that process of understanding the anatomy, understanding the drainage pathway, and keeping your hand on the wall during the dissection, I think is one that really allows the surgeons to safely dissect that frontal recess and to expose that frontal ostium completely.
When you're looking at the scan and you're planning the surgery, ahead of time, how do you decide how extensive you're going to be with the frontals ahead of time? So we'd said, a mini FES and a full house. And I feel like with the frontals, are we talking as a mini FES, just like a frontal sinusotomy, and the full house is always like taking the inner sinus septum down? Like, how do you decide when you're going to take the inner sinus septum down or not? And maybe that's a better question, or is that the main decision maker? Or how do you go about that?
Yeah, because full house FES is full house FES. That means all the cells are removed and the frontal ostium is completely exposed. So if we go into the frontal recess, we take in everything out. We're exposing the frontal ostium. Now, your frontal ostium may be small. So, we get frontal ostium that may be 3 by 2 millimeters or, 3 by 3 millimeters. That's a really small frontal ostium. But don't try and enlarge it. The worst thing you can do is put a drill up and make a small frontal ostium a little bit bigger. You are guaranteeing a closure of that frontal ostium. So what you're trying to do is you take all the cells away, preserve the mucosa. This is really critically important. Don't strip the mucosa around the frontal ostium. Preserve the mucosa, take all the cells down. So we never do a partial surgery of the frontal ostium or frontal recess. It's always got to be complete. And so when do we decide to put a drill in? So we put a drill in when we do a frontal drill out, which is a draft 3 or modified Lothrop. We don't put a drill in to make a small opening a little bit bigger. So it's either a big operation, a Lothrop, or a frontal recess dissection. So, I basically have 3 surgeries: a mini FES, a full house FES, and a frontal drill out. And the frontal drill out generally is for patients who've had previous surgery, who have failed that previous surgery, and we really need to take out, adhesions or a recurrence of polyps in that small frontal ostium. We will occasionally do a frontal drill out primarily, but generally it's for a tumor, an IP, or CSF leak in the frontal, or access, or some other reason. It's generally not for chronic sinus disease per se.
Yeah. So even if it's small, you're going to give it a chance, the first go around.
Absolutely.
Just try to preserve the mucosa and just,
Yep.
Make sure that you've removed all the cells and then see how it heals.
Let's say the patient's got a small frontal ostium. You've got a really small frontal ostium, and if you've got you guys in Texas, you've got the kingdom of allergic fungal sinus disease. So if you've got extensive disease with fungus, etc., lots of inflammation in those patients, and they've got a small frontal ostium, I say to them, listen, we are going to do the surgery for you, but there is a significant chance with your likelihood of recurrence of your fungal disease that you might need a bigger operation as a second procedure. Now, we did actually write a paper where we looked to see if we could predict who would fail depending on their size of their frontal ostium or the extent of their disease. So we looked at a number of factors. We looked at the presence or absence of fungus. We looked at whether they were Samtis triad. We looked at whether they had significant eosinophilia. We looked at whether they had the size of their frontal ostium. We looked at the London-Mackay score, and we sequentially added these factors up and said, okay, if you've got all of those factors, or if you've got 5 or 4 or 3 or 2, what is your likelihood of failing your full house FES surgery and actually coming to a revision surgery? So the idea behind the paper was see if we could avoid a second surgery, just do the correct surgery at the first procedure. And they were additive. In other words, if you had all of them, you're much more likely to fail if you had none. So they were additive, but we could not predict. There was no accurate predictive factor that we had patients who had small frontal ostia and allergic fungal sinus who did perfect afterwards and had a healthy outcome, and patients who had, relatively mild London-Mackay score and a relatively big frontal ostium who failed, who needed a second surgery. So there really wasn't something which was predictive.
I wanted to ask you a couple of questions, and it might just go back to sort of, how you, do your surgery or what you have on your table. One question I had was, how do you use your angled scopes? Do you graduate up from 0, 30, 45, 70, or are you like, okay, we're about to go to the frontal, so give me the 70? What instruments do you have on your back table? Like if you're going to do the full house FES, so we want to open up the sinusotomy, what do you have available? And I know we said, hey, for a draft 3, fine, we're going to use a drill, but otherwise no powered instruments. Is there any role for microdebriders, perhaps for the anterior ethmoid? So tell me about those. And this might be another question, but do you ever use a balloon? Sorry, just put there. Answer all of those questions, PJ.
That's an easy one to start with, because we don't actually have balloons available in Australia, and they brought them to Australia, and they launched them in Australia, and what happened is that they didn't have a reimbursement code for them, and so nobody used them because there was no reimbursement code. So if you used a balloon, the patient would have to pay out-of-pocket expense for the balloon, and they were more than $1,000 for that. And so the surgeons would say, well, what advantage is that balloon going to give me other than putting that patient $1,000 out of pocket, because the insurance companies wouldn't pay for it. So there was no reimbursement code, and so they nobody took up balloons in Australia, and so the companies withdrew them. And so they don't even have them available. I think there might be one of the companies bringing them in again and having a second go at that. But, fascinating if you think about it, how extensively balloons are used in the US, particularly in the sort of office setting. And now in Australia, they're not used at all. So, fascinating if you think about it in terms of healthcare expenses and everything else that goes with it. And, whether balloons, I think balloons are fine for many disease. Again, if you've got minimal disease, fine. But, balloons are not good for patients who've got extensive disease. I think you really need to do a proper surgical procedure to do the dissection for that. So that's the balloon one. We can put that one aside now. So if we go back to the microdebriders, so on every single sinus case I have a straight blade, and I have a 60-degree blade. And I really want the tip of my blade, the 60-degree blade, must be 3.5. I can't use a 4 because 4 is too thick. You can't see around a 4 in the frontal. It's too big. So a 3.5, which is actually a pediatric blade, but that's the standard one that I have. And it must be rotatable, because I often want to cut mucosa posteriorly or laterally. And if my blade's not rotatable, then I have a problem. So, I need to have a rotatable blade, and it needs to be a 3.5. It needs to be, and I think it's vitally important because when you're in the frontal, the other instrument that's really important are giraffes. So I have 45 to 90 giraffes, so front to back and side to side. Generally not through cutting. I do have them available if I want the through cutting, but generally just the grasping ones. And what I try to do is I use a malleable suction curette, which is my major dissection instrument. And the reason that I use a suction curette is that I see and used to see so many surgeons who would put the endoscope in, take the suction, clean the area that they're going to operate on from blood so they could see where they're going to take the instrument they were going to then use, a curette or whatever it might be, try and place that curette with an angled scope into that area, and just as they're about to place it, the whole area covers with blood. So then they take the curette out, put the suction back, and the process repeats itself. And it's such a time-wasting procedure. So what we would use is a suction curette. So the suction clears the blood away, and then you can utilize the instrument to do the dissection and clear the blood away at the same time. And so I think that's really important instrument. So using that to fracture. So what I do is fracture the cells with that, and then generally with the giraffe, I will try and take the bony fragments out, leaving the mucosa behind, and then I put the microdebrider in and then trim the mucosa. So I want to try and preserve that mucosa. If you try and grab anything with the giraffe and pull, you often strip the mucosa with the bone. So you try and take the bone out without taking the mucosa with it, and then trim that excessive mucosa to preserve that mucosa in the frontal ostium. So, I think those instruments in the frontal sinus are really important. The other instruments I think are vitally important is the cobra. The cobra is like an angled kerosene. It's got a 45-degree angle on it. That's most of the instrument companies produce that. And then Hoseman, which is the circular punch. So, all of my frontal sinus instruments, suction curette, the giraffe forceps, the debrider blades, the Hoseman, the cobra are vitally important. If you don't have those instruments, you shouldn't be doing frontal. That's the minimum that you need for a frontal, because you can't reach around the corner with the other instruments. And generally speaking, so when we open up the agonizing cell, we'll open it up with a Hayjack-Koffler punch and a 0-degree scope. And then once we've taken the roof of the agonizing down, we'll switch to the 30, because we want to see that hand on the wall, that frontal process. And I would say I would do 80% of my frontals with the 30 alone, nothing more than that. And then only those that have a very prominent beak. So if you have the beak sitting here and you have the skull base, if the beak is really prominent, the angle that you've got can be more than 70 degrees to see your frontal ostium. So if your beak is not there, you can use your 30 easy. But the more prominent your beak, the more likely you are to need to switch to that 70-degree endoscope. And so then to switch to the 70 to be able to visualize that ostium and actually work within that ostium to take any cells away. So on my tray, I'll always have a 0, 30, and a 70. Sometimes we'll have a 45, but generally speaking, the hospitals don't often provide both a 30 and a 45. So one of the two, a 70 and a 0.
Yeah, I like graduating it up because otherwise I lose my orientation if I jump from like 0 straight to, so I like a nice 30 workhorse before I need to start and then kind of see up as well.
Yeah. Now, I think one of the things people don't understand is that actually positioning an instrument with a 70-degree endoscope is actually very tricky. It's not easy to do. And so, I don't know how often you've watched a resident who's sort of slightly inexperienced try and put a 70-degree scope with an instrument into a frontal ostium or frontal recess. And they really struggle because the position is really difficult, because you need a very angled instrument to see the tip, because 90% of the time your endoscope is above your instrument. It's not the other way around. So dropping your endoscope below the instrument, you're looking at the back of the instrument, so you're not looking at the tip where it's working, and you're much more likely to have a problem. So generally speaking, you've got a very angled instrument, which is difficult to position, and an angled telescope. So we try and limit our use of our 70, especially, and you should, if you're inexperienced, try and limit the use of your 70. Try and use a less angled endoscope when you can.
Do you put a big shoulder roll underneath, or how much head extension is helpful to you for
so
frontal
really
work?
Really important. The thing is that your head position in sinus surgery should always be exactly the same. You should never have flexion or extension. So I like to have my skull base exactly at 90 degrees to the bed, always, in every single patient. So if you change that orientation, again, so if you're always operating in this angle against the skull base and suddenly you've got extension and you're now operating like this, or you've got flexion and you're losing your orientation, keep your head position exactly the same every single time you do surgery. Don't change it. Don't extend the head for some surgeries and not for others. You're going to go through the skull base if you do that. You're going to lose your orientation. And that's why people say to me, do you do the axillary flap for all your surgeries, even if if the patient doesn't have a frontal sinus, for instance, we've got an absent frontal sinus, you're not going to go there. Do you still do an axillary flap? I say, yes, I do, because the approach into the posterior ethmoids is always exactly the same trajectory. So I'm always doing exactly the same trajectory. I'm never changing my trajectory. So I'm never going to get that disorientation or get lost when I'm there. And I think just a safety issue.
Yeah, just do it the same way every time.
Yeah, every time.
Yeah, I think that makes a lot of sense. Speaking of some of the complications that you talk to patients about when you're thinking about frontal sinus surgery specifically, I think the one that most of us are worried about is stenosis, like when you have that very small opening and, I don't know, maybe you accidentally strip some mucosa or something.
Oh, that happens. Don't worry. To everyone, including me. And I'll swear when that happens, you'll hear the expletive come out my mouth when I, inadvertently you've tried to grab that little piece of bone and somehow that little mucosa has got trapped with it, or for some reason that microdebrider blade has just sucked it in and it's gone, and there's mucosa's gone now. So yeah, that happens.
It's the worst. So, what kind of speak to the complications that you're thinking about in that area specifically?
I think that's probably now the probable optimal time for us to come to how we manage our patients post-op, because this is, you've stripped the mucosa inadvertently or in error, and or the patient just has a very narrow frontal ostium, or the patient's got significant inflammation. These fungal sinus patients who are very bloody and got a lot of inflammation, what do we and how do we manage those patients who have significant inflammation? So this is the post-op management. And, and just a disclaimer, I'm going to talk a little bit about Chitogel at the moment, and I'm a shareholder in the company because we designed the product from the ground up. We started this research on this product in 2005, and at that time there was no dissolvable products in the nose and the sinuses, and so we were really looking at trying to develop something which would have the benefits that you want for your post-operative care. So ideally we want something which is hemostatic. We want something that prevents adhesion formation, that actually stops the adhesions from forming. We want something that is going to preserve the ostium. So we want the narrowing of that ostium to be avoided if possible. And we want long-term mucosal health. So you want to prevent those infections from happening on a regular basis. And with that, the return of inflammation, edema, and disease within that sinus. And so, we want something that sort of covers all of those categories. And, we do have at the moment, like we have, stents that release steroids, and that's great. So that steroid release helps prevent that adhesion formation and tries to preserve that ostia. We do have nasal packing, for instance, that, you have sponges and stuff that you can put between the middle turbinate and the lateral nasal wall. But the problem with most of these products, and I think that's where we've tried with Chitogel to actually have a product that covers all of these, is that it's hemostatic. The dextroanaldehyde portion of it prevents fibroblast migration, so you have that adhesion prevention, and we have the osteopreservation up to 70% osteopreservation compared to the control side. All the studies that we did Chitogel on one side, nothing on the other. So it's in the same patient, same post-operative condition, same everything, just comparing one side to the other. And so we also showed that the long-term mucosal health was quite different, and that over a 12-month period, you had a 70% decrease in infections in the same patient on the side that received the Chitogel versus not. And that's all due to the microbiome restoration and the glycerol within the product, which the healthy bacteria use as a food source to improve that. So, I think that having all those factors is important. But if you think about it, a sponge contacts the middle turbinate and the lateral nasal wall. It doesn't contact the frontal ostium. It doesn't contact all the raw surfaces. A steroid-releasing stent only releases the steroid in the area that it's placed, which might be with a mini, might be the frontal ostium, or with a maxi, might be the ethmoid. And the other products, whereas if you have a gel, you want the gel to be in contact with all the raw surfaces. So, for instance, with Chitogel, you actually put the gel into the frontal sinus. So you fill the bottom of the frontal sinus itself, the whole frontal ostium, the frontal recess, the whole ethmoid cavity, and the ostia itself. So all of the raw surfaces are contacted by your biologically active product. So you really want your biological active product to have that biological activity on all your surfaces, not just in limited areas, and to have the effects of hemostasis as well as having the adhesion prevention and the long-term mucosal health. So, for us, and I've used the product now for many years, and we've been really impressed with the long-term outcome that it delivers for our patients. And, we really didn't expect to see differences in the microbiome between the Chitogel side and the non-Chitogel side, because we thought, you wash the nose, you're going to wash the bugs from one side to the other. You're not going to have a difference. And so when we did the research, it was quite interesting to see that there was a statistically significant difference between the bugs on the one side and the other. Yeah, so, it's a really interesting outcome.
Do you have your patients wait to start saline irrigations for a day or two after placing the Chitogel?
So that's really interesting. So we actually start the washes the next day, and by the time we see the patients at 2 weeks, 6 weeks, 3 months, and 12 months generally is our follow-up period for them. Unless there's problems, then they come see us, more frequently. But when we see the patients at 2 weeks, generally the gel's gone and it's been washed away, so it dissolves, quite nicely with the wash. But it was interesting. I had one of my surgeons in the US had a prison population, and they wouldn't let them wash, and so he put the Chitogel in and saw them at 2 or 3 weeks afterwards, and they didn't wash at all. And he said they looked absolutely fantastic. And so we're starting a study now, because we don't want to advocate it yet, because we haven't done a study to show, yes, it is or no. This is the anecdotal experience. But we're starting a study now where we're not going to wash and see what the outcome is compared to when you do wash. So it'll be interesting to see.
Oh my gosh!
And that's it's one of the benefits for kids, is that I think you can put it in kids, and you don't have to do the debridements because it disappears, and you don't have to do. I think for kids it would be beneficial. Yeah.
I can only imagine all the patients that are going to be like, I don't have to
want
do
the
my nasal
Chitogel.
rinses.
I'm not give me that Chitogel. This might be a silly question, but I assume that if a patient has a shellfish allergy, no Chitogel?
No Chitogel.
Okay.
It is it's highly chemically modified, and actually the chemists say to us that the antigens that would be there are so chemically changed that it wouldn't matter. But we can't take the risk. You can't take the risk. So you just say, if you've got a shellfish allergy, no Chitogel. Because it's made from prawn shells, the chitosan. But I think that should be the same for all chitosan-containing products, because they're all made from the same base product.
And is that for every sinus surgery, or is that just when you're,
No,
worried
I use it
about
for all my sinus surgeries because of the hemostatic benefits that it has. So it's very hemostatic. And so, one of the things that us as surgeons don't want to be done is called back once we put, patient just out of the operating theatre, we call back for a problem afterwards. So I use it in all the sinus, whether it's a mini fez, full house fez, or a fibril drill out, they all get it.
So when you place it, it makes sense. You're filling up the frontal sinus, or at least the recess, and anywhere you've dissected around the frontal sinus, of. For your ethmoids and like max,
you fill the ethmoid cavity. Yep, fill the whole
just
ethmoid
shoot
cavity.
it in, fill it up. Okay.
Yeah. So there's 22 mils. So there's 11 mils per side. So there's plenty of gel. So you fill the whole ethmoid cavity, the space between the middle turbinate and the lateral nasal wall. If you've had significant disease in the maxillary sinus, for instance, if you've got fungal or polyps or whatever else, actually placing it in the actual maxillary sinus, we fill the sinus as well. Sometimes then, if you fill the maxillary, the sphenoid, and the frontal and ethmoid, you might run out of gel for the other side. But if you just fill the frontal ostium, the ethmoid, and around the ostia of the sphenoid and maxillary without filling the sinuses themselves, then 22 mils is plenty.
For your patients that have had skull-base surgery and you've done your repair and your packing, do you do Chitogel in those cases as well for any reason? Or
so it's not FDA approved for intracranial use, or where you've done a large dural exposure. So we don't have FDA approval, but we have done quite a lot of published studies where we've put Chitogel in contact with the brain tissue in animals and shown that there's absolutely no toxicity whatsoever to brain tissue. And in Australia, we can use it in, say, for instance, post-pituitary surgery. We would use it, but we haven't used it for where you've done a large skull base resection and you've then repaired that skull base and then use it as a stent. It's not from a stent perspective, it doesn't provide a lot of tensile strength. So generally speaking, if you've got a floppy middle turbinate or a middle turbinate that's been pushed laterally by a deviated septum, which you've now corrected, and that retro-curved middle turbinate, we would often suture that middle turbinate to the septum as part of that post-operative period in conjunction with using the Chitogel, because it doesn't have a lot of intrinsic sort of strength like a sponge would in terms of preventing that lateralization. So if you've got a turbinate that looks like it's going to lateralize, you really need to look at helping that as well. So, and that's why one of the things with skull base, you want something with a bit of rigidity, a little bit of packing force that's going to prevent displacement of that repair. So I think pituitary surgery is fine, but if you've got a large skull base defect, we would tend to put either gauze packing or balloons and things that have a bit of rigidity to support that skull base during that initial healing period.
And with the Chitogel, I have not used it before. Is it just ready to go off the table, or do you have to kind of like mix it up? Or
that's the one reason why it hasn't taken the market over, I think. So you've got to actually mix it beforehand. And I think that's the problem, is that it's not on the shelf. You can't just say, okay, I'll use it now, open it up, bang. So, I think generally speaking, the surgeons that are using it, you open it up at the time that your scrub tech sets up the tray, and they do mix the gel with the powder, the buffer with the powder. And then 5 minutes before you actually want to use it, you've got to mix the chitosan and the powder buffer combination together. And so you've got to have that sort of pre-prep. If you don't have that pre-prep, you can't just take it off the shelf and use it.
Got it.
And there's no surgeon that I know that if you tell them, that they're at the end of the surgery and that they're going to have to wait 15 minutes, they're not going to wait 15 minutes. It's never going to happen. No. So yeah, that's the one downside, and that will limit its use. And what we found is that the surgeons who see the benefits at the long-term benefits and the health, that they are quite happy to use it basically on every case. And so the scrub tech just does it as a routine.
Learn how to use it.
You just have to think about it before the end.
Yeah. So you'd mentioned, in terms of things that can help prevent stenosis, we talked about the Chitogel, we talked about steroid-eluting stents, we've mentioned, being meticulous, dissection, prevention of stripping mucosa. Have you noticed biologics playing a role in helping prevent stenosis?
I don't know about preventing stenosis so much, but, biologics are certainly, making a big difference to our patients who are recalcitrant, in patients who you've done really good surgery on, and their polyps recur and all the disease recurs. And, they are a godsend in a way, because, these are patients who we've struggled with. And, in the past, we've just done repetitive surgeries on them. I used to say to them, looks like we need to mow the grass again. The polyps have come back. The bony work's done. All your sinus cavities are widely patent, but we're unable to control the recurrence of disease, whether it's a Samter's patient or whether it's allergic fungal or whatever it might be. We need to go in and mow the grass and clean the sinuses, and, that's what we used to do. And now with biologics, you put them on biologics, especially if they, in the type 2 inflammation, and wow, bang, you've got a patient who's happy and surgeon that's happy, and, it's a good outcome. I think the downside of it is cost, and the other is the fact is that when we take these patients off the biologics, they seem to recur. So these are the two issues that biologics address. I think the other issue that is not addressed is the non-type 2. So, increasingly we are seeing non-type 2 inflammation. So generally speaking, type 2 is eosinophilic driven, and non-type 2 is either lymphocyte driven or lymphoplasmacytic. So they have either lymphocytes and plasma cells in combination, which would be called a lymphoplasmacytic, or lymphocyte. And a lymphoplasmacytic seems to be the most common. And so lymphoplasmacytic is not suitable for your biologics. It's not a type 2 disease. And so we have found that these patients do extraordinarily well with good surgery and long-term clarithromycin. So we would put these patients on, say, clarithromycin 250 milligrams daily for 3 or 4 months. And they do extraordinarily well. And when they finish that 3 months treatment, they don't seem to relapse. We seem to be able to keep them under control. So, I think there are areas which the biologics don't address, which are also quite prevalent, which we need to really still do really good surgery on, but that we do have some other medical therapies that we can help these patients really recover well.
For your patients who are on biologics and who are doing well, do they still have to do their rinses?
Yes, they do.
The answer is always yes.
Yeah, we see that it's like an additional control. I think that they get some benefit without the rinses, and probably some of them, they do them much less frequently than what they did. But if they don't do them at all, they don't get as good an outcome as if they. So we still keep them on the palmar cord washers, despite the fact that they're on biologics. Yeah. So
rounding things out, as far as following your patients who are post-op, you said you or when do you see your patients back after surgery?
Yeah, so first visit is 2 weeks, and then it'll be 6 weeks after that, and then if they're really good, 3 to 4 months after that, and then 12 months after that. So the drill out patients I follow up for years, because the maximum stenosis is 12 months, but they can still, you really want to have them, 6 monthly for at least a couple of years, 2-3 years, the drill out patients. But the frontal sinus patients generally always a year. Some of them who've got the tendency to have sort of issues, I will see them 6 monthly for a while after that, depending. And it's all about keeping disease control. So for instance, a lot of people used to say that if you've got, Samter's triad, aspirin exacerbated respiratory disease, that you're incurable. that you've got a disease which is a metabolic abnormality, and you're going to keep growing your polyps, and that's the end of it. You're never going to be cured. So this patient group, we've seen that up to 50% of them, if we've done a frontal drill out, which we tend to do with these patients to get good control and exposure of the frontal sinus, and we've done a complete sinus operation on them, and if we keep them on Pulmicort, we can keep these patients healthy indefinitely, and so they don't recur, and it's not an incurable disease, and it is a disease which you can get control. And also the fungal sinus patients, exactly the same. But these patients have a tendency to have issues, and so we like to follow these patients up at least 6 monthly on a regular basis, and we keep them on Pulmicort washes. And you may or may not be aware, but we did a whole lot of research on Pulmicort because we found that Pulmicort in patients who had infections on its own would cure the infection. So we thought, why is that? It's a steroid. Why has it got why is it antibacterial? Why are we seeing the infection disappear? So what we did is we went in the lab, we grew biofilms on pigs, and then we put Pulmicort underneath it because people were saying it's the inflammation that is, the steroid is driving the inflammation away. That's what's taking the bacteria away. We said, well, let's take the inflammation out of it. Let's just have a look. So we showed that Pulmicort actually killed the bacteria biofilms, and we said, well, why? So we wrote to the Pulmicort manufacturers and said, can you tell us exactly what's in Pulmicort? And they wrote back and said, no, we won't. So I said, okay. So we sent it away and we analyzed it, and we actually found out exactly what was in it. And then we then tested each of the separate ingredients in it. Now, Pulmicort budesonide is insoluble. Okay, so it needs a whole lot of adjuvants to actually make it soluble. And so the adjuvants that they've put in it, 2 of them are highly antibacterial. So one is tween 80 and the other is EDTA. And so the EDTA and tween 80 in Pulmicort has actually got a really strong antibacterial activity. So keeping the patients on Pulmicort post-op is not just the budesonide, the steroid, but it's also the antibacterial agents which are in the Pulmicort, which then allow that antibacterial activity. And so the theory that I have, and this is just a theory, so you have patients who get sinus disease, okay? When do they get sinus disease? Typically in their 30s or 40s. So how come they've had 30 or 40 years of health and suddenly they've got disease which is now incurable suddenly? Why have it taken 30 years for this to occur? So I think it's an initiation and sensitization of the immune system. And there's a theory about IL-33 and viruses, and I won't go into that now. Maybe we'll have another podcast and I can go into all of our theories about chronic sinus disease and the evolution of it. We've done a lot of research in this area. But anyway, so the sensitization of the immune system. And post-operatively, what we want to do is desensitize the immune system. So we want to ratchet back that sensitivity. We want to decrease the amount of eosinophils and mast cells in the mucosa of the sinuses. And the regular Pulmicort, because it takes away the stimulation both of the bacteria and of the antigens that might be in the air that the patient is exposed to, that desensitizes it over time. So I'd say typically to a patient who's got really bad disease, I want you on the Pulmicort for a year, and then after that we'll start playing with the dose. And so if your immune sensitivity has been ratcheted back, you've been 100% healthy for a year or 18 months, we can then start reducing that disease. So we go from Pulmicort every day to Pulmicort every second day. Do that for a few months and then go to twice a week. And we see what your baseline is that we can keep you at. Sometimes we can get you off it and you can only use the Pulmicort for exacerbations like colds, or you'll need a baseline of once or twice a week, which is just enough to keep your immune system in control. So these are the patients that we get them to that point and then we can discharge them because we've basically cured them, because we've got them at that long-term healthy control level. And it's all about the sensitization and desensitization of that immune system. So ratcheting back that immune system, which had been ratcheted forward by some process which caused the disease initially.
That's cool. Well, we'll have you come back for PJ's theories on chronic sinus disease.
Yeah, exactly. Yeah.
But as we unfortunately we have to land the plane, but any final pearls or, where you see future innovation for frontal sinus work, frontal sinus surgery, frontal sinus disease?
I think that the innovation is going to come. So how come we evaluate surgeons for their to get their board, their certification, by asking them to talk about surgery? So you'll give them a scenario. So this patient comes with this, this, and this, and what are you going to do? Oh, I'm going to put the patient to sleep. I'm going to have consented the patient. I'm going to have them in a Trendelenburg position. I'm going to do this. I'm going to do that. They talk you through the surgery. So if you're going to certify a pilot, are you going to get him to talk his way through how he flies the plane? Or are you actually going to test him how he flies the plane? So for me, the models allow us to technically test surgical technique. So where we want to go in the future is we've got 10 different models. So we'll give them the CT scan, like I showed you, of that particular model. We'll get them to make the assessment. We get them to make a surgical plan, and then they're going to operate. And then you're going to assess them. And because every model is reproducible, you can do it to 20, 30, 40 candidates, and they all get in exactly the same exam. There's a standard. And you can set the standard. You can set the standard for understanding the anatomy, for planning the surgery, for the technical skills that the surgeon is demonstrating on that particular model. And now we have models now for mastoid surgery. So we have cholesteatoma within the model. So we can say, okay, here's a patient who's got a poorly modified, poorly aerated mastoid. There's a cholesteatoma, shows how you're going to take it out. We've got the same process. We've got the same for rhinoplasties. We've got patients who've got beaks, humps and everything else. You can do that. So there's enough through ENT where we can start to standardize your technical expertise and actually have our patients who are operated on these patients, you can say to them, we have now qualified the surgeon and we actually know that he is technically capable of doing the surgery. And, why are we not doing that when we, as I said, the analogy to pilots in planes, we would put them in a simulator and we would test their ability to manage a problem. And we're not doing that with surgeons, and I think we should.
No, I think that's super interesting in terms of testing in medical education and, what that would also mean in residency training, right? You would think that some of that is already done as we pass residents through, but that's super interesting. Are you on any social media in case our listeners want to reach out to you, PJ?
None. Too old. Too old. I'm technically challenged. So no. So if anybody wanted to contact me for any reason, very easy. pjwormald@gmail.com.
Awesome. Or they can reach out to the show and we can always connect you as well. Yeah.
Wonderful.
No, thanks so much, guys. I really enjoyed the time with you, and good luck. I hear your podcast is super popular, and I'm sure it's going to continue.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.